Next, I would like to invite Dr. Isha Chaudhari to continue with her presentation. Dr. Somsila has a presentation in another session, so she will join us little later. Can you please come and change the, oh, you can go on the other side, yeah. You can upload her talk on the other computer.
I'll switch. So very good afternoon, everyone. So William Shakespeare once said, "What is in a name?" But there is something in the name. So when we're talking of peripheral ulcerative keratitis, we have the word peripheral in the name. So why only peripheral? So peripheral lesions can range from Tyrion's marginal degeneration to accumulation like a BSK, other PUK and perforations. They can be a pannus, they could be a marginal keratitis. We've seen a lot of peripheral lesions. So what's special about a peripheral ulcerative keratitis? So it says that the word ulcerative and keratitis is in the name. Ulcers can be both peripheral and central. So what's different? Why is PUK always peripheral? So before I go into that, I'll just explain the pathogenesis in a very brief way. So normally autoantigens are not recognized by the body's immune system. However, in this disease, the autoantigens activate the B cells to release plasma cells against the autoantigens, and these autoantigens are then they release more antibodies by activating these plasma cells. These autoantigens and the antibodies to these autoantigens, they combine together and form immune complexes. Now these immune complexes are large molecules. So as our peripheral cornea has...
Can you stay back there?
Yes.
On the cartoon you go back?
Oh, okay.
So does everyone understand in very simple terms when we say autoimmune or immune complexes, what does it mean? What it means is that normally the cornea is not recognized by immune system as foreign. Body has a surveillance mechanism with lymphocytes, and they come sample each tissue of the human body, and if they find there is an alteration or there is abnormality, they signal, they express MHC class 2 molecules, and then they secrete cytokines, tell other cells that there is some intruder because they think that it's not a normal structure. So that is where we call autoimmune, meaning our immune system has turned against us. So that is what, and then the immune system gets activated, then innate system, the complement, all they combine, they are trying to protect us, but they don't realize that it is part of your human body. So that is why autoimmunity is little more difficult to treat, because every cells, new cells come, they will survive for 2 to 3 months, and then again the new cells will start behaving the same way. So we will talk when we are talking about the immunomodulation, why you need to continue for a longer time. At the moment, simple term, autoimmune means there is something alteration in the structure of the cornea or microstructure that is not recognized by the body immune system as self. So there is an important distinction between self versus non-self by the immune cells. Please carry on.
So now we've understood why there is autoimmunity here, and those antibodies and antigens, they form complexes. Now these complexes are large complexes. So if we see here, it's only the peripheral cornea that has access to blood vessels and lymphatics that are associated with them. The central cornea is devoid of these blood vessels. Also, the stromal lamellae, the cornea in the periphery is thicker, and the stromal lamellae are loosely arranged. So when these immune complexes are formed, they come and enter the peripheral cornea, but they get stuck in the peripheral cornea because that's the only place where they can enter, and they are not able to move forward up to the central cornea due to their large size, and hence the peripheral cornea. So here, when the immune complexes get accumulated, they activate the complement both through the classical and the alternate pathway. The complement activation leads to release of cytokines, which activate the MMPs and which in turn leads to the dissolution or the melting of the cornea in the periphery. So the points that lead to just the peripheral part being involved in peripheral ulcerative keratitis is the presence of vessels and lymphatics only in the periphery, the looser arrangement of stromal lamellae and the higher thickness. Also, the peripheral cornea and the limbus and the conjunctiva near it has reservoir of antigen presenting cells that through the lymphatics goes and presents these autoantigens as foreign. So these autoantibodies reside in this area, and the T cells in the tear also exacerbate this immune response. The other thing is that the contiguity and proximity of the conjunctiva, episclera and sclera to the peripheral cornea also expose it to the antigens, and this can get secondarily involved. So we've covered most of these points. Also, the complement C1 and IgM, again like immune complexes, are large molecules and don't penetrate beyond the peripheral cornea. The peripheral cornea also has higher replicative capacity both for the epithelium and the endothelium, which is the immature cells that get affected faster than the mature cells in the center. Also, the area is less sensitive owing to less neural innervation. Immunologically, there is higher expression of MUC4 gene, which when defective does not protect or regenerate the epithelium as it would in normal cells. So we've covered most of these things, and this is a QR code. We have prepared a handbook. You can
Please go ahead.
yes, so you can scan this QR code and download the handbook that we've prepared. It will have all this information and also the references to what we've quoted.
And please check it's working or not. Then only we'll go to the next slide.
Yes.
Can you go back to your slides?
Yes.
Yes, yeah, the ischemic this one, next one, next. No, not backward, far. Yeah, this one. See, this is a. I also showed you that picture. When you do pterygium surgery, there are three kind of problems that can happen. One is something called SINS, surgically induced necrotizing scleritis. I will show you that in my presentation. Then what this picture is typical of a ischemic necrosis, and this probably is due to maybe excessive cautery or healing problem. Third, it can be a infectious scleritis at the site of surgery. So all three are very different, and it's very important to make a distinction because the treatment is very different. For SINS, you need immunomodulation. For ischemic necrosis, you need to promote healing, and for infection, you need to make diagnosis and treat with antimicrobials. So these are the kind of pearls